The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hi, everybody. We're here today for the next episode of TMD Demystified. I am Tony Urbanek, and our episode today is entitled Noises from the Joint. Well, which joint? Obviously, the temporomandibular joint. Noises from the joint. This can be an interesting, hopefully brief, but very impinging episode. Noises from the joint is like noises coming from the attic. Gets your attention. It's like, what was that up there? Honestly, have a lot of experience and a lot to say about this simple, what should be a simple concept, which actually isn't. But there are a lot of noises that come from these temporomandibular joints. And if you have had any experience at all treating patients with TMD, or even listening to patients with TMD, or have a family member or friend with TMD, more often than not, one of their first comments or complaints is noise from the temporomandibular joint, various noises. And it's always starts out confusing, just like noises from the attic. It's like, what was that? Is the noises change? They vary all over the place. They vary over time. And unless you focus in this area, it doesn't, even as a practitioner, sometimes it doesn't make a whole lot of sense. So I'm going to try to straighten out some of that for you, and also encourage comments and questions from you, because this is one of the common things. I mean, tremendous numbers of people have noise and either do not have other symptoms or not aware that the other symptoms that they have are related to temporomandibular joint disorder. So let's just let's get this out again. And just let me review very briefly for any newbies or people that are not focused on temporomandibular joint disorders. And I like to use familial terms. I can use all kind of doctor terms, but familiar terms, which is ball and socket. And this is how I talk to patients. And between the ball and socket of the condyle and the glenoid fossa is a cushion that are known as meniscus. As in any other joint, when this joint is overused and breaks down, it creates inflammation and degenerative changes. Now, the degenerative changes can be on the surfaces of the bone and the cartilage on the surfaces. They can be on the meniscus itself or within the meniscus itself. But obviously, it is the degenerative changes one way or another that's one way or another create the noise. And we'll go over the different kind of noises that I can recall and experience after talking to thousands and thousands of patients about this problem. But here's the basic on it. You have a condylar head sitting in a glenoid fossa, and between there is a meniscus. And then when this jaw moves, it will make those noises. Now, I mean, self-evident, but again, the simplicity of it. There are two basic kinds of noise creations. There's noise that is created by the malmovement of the meniscus, and then there are noises that are created associated with the degeneration of the bone and the bone on bone. So in a normal in a normal patient, you have ball socket and the cushion, which is supposed to slide silently and slightly within the glenoid fossa as the ball rotates for the first half and then comes down the surface of the bone to get your further opening. So the most common kind of noise is the click, 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 and kind of get into the clinical part of this a little bit. It is extremely common for young females, not so much males, but extremely common for young females to complain of that click, 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 click early in adolescence, anywhere between 13 and late teens. No pain, no pain at all, but they will tell you at some point in their history down the road in their 20s and their 30s, oh yeah, I remember when I was 15 years old, you know, I'd click, click, it's clicking all the time. I didn't worry about it. I didn't think it was important. Well, first of all, just to go back and review a little bit, that the meniscus itself will become loose as the ligaments that hold the meniscus in place are under the influence of the inflammation. So the ligaments start loosening up, and in a healthy joint, that meniscus is supposed to move a little bit and silently, a little bit and silent in a healthy joint. And as ligaments loosen, the meniscus starts to move more, and it will come in and out from underneath the condylar head. And that's where you hear the click, 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 click in the early stages of temporomandibular joint problems. As most of you know, as the meniscus continues to loosen, then the meniscus will come forward out of the glenoid fossa and either partially or completely ball up into a little ball. And now when you open, you go to open, you get halfway open, you bump into your own meniscus sitting out there in front until you put enough pressure on it until it clicks back, usually with a much louder noise than the initial click, 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 and usually quite a bit of discomfort. And then if that's ignored long enough, and I see those cases every day, it takes a while, but then after 5, 10, 20 years of this going on, the meniscus balls end up in a little ball, dislocated meniscus. And now when you go to open and rotate forward, you bump into the meniscus, you can't get past it. It doesn't click back at all. And that's when you get your complete closed lock, and the patient presents with an inability to open to about 25 millimeters. I mean, that's all they can do, 25 millimeters, 45 to 55 being normal. And they're only halfway open because they can't get past the meniscus, and the meniscus is not coming back over the top of the condyle any longer. So that's your typical closed lock and the noise that goes with it. Now, the second kind of noise is the noise associated once the meniscus is pretty well degenerated, and that doesn't necessarily have to take 40 years. It can happen rather rapidly depending on how much force the bruxism or other causes for degenerative change within the joint occur. So, but once the meniscus pretty much breaks down, and either you have worn a large hole in the meniscus, or the meniscus has the consistency of butter, or worse, doesn't even exist at all, then you get the bone-on-bone experience. And by then you can see, even on Panorex, you can see significant change on the condylar head. You see flattening. You'll see subcondylar cysts, which are just usually dark, little cystic cavities. They're darker, not lighter, darker areas, a cyst area underneath the surface of the condyle, subcondylar cysts, which indicate degeneration, significant degeneration over a period of time. But those kind of noises differ significantly from the typical click, 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 or pop, which is the condyle coming back over the surface of the meniscus as the meniscus pops back when it's temporarily dislocated. So we have two characteristics, two categories of noise. I don't want to over-categorize this self, but if you understand the category, then you can understand kind of what stage of this process is going on, because it is a progressive process. And as I said earlier, the click, click, click is always the earliest and usually not painful at all. And then when it gets into the meniscus gets really loose, you get into that popping when it clicks back. And that when it does click back, that is usually associated with quite a bit of pain. And then you get into the locking where the meniscus is totally dislocated, does not return to anywhere near the proper position. All right, so you have the click and the pop, and the patient will come in and they will give you their rendition of the noise. And don't blow it all off, because right away they'll tell you by applying what I just said, you'll have a better idea of what stage of their problem they're in. I mean, if you have a patient sitting in your chair or you're doing an exam, whether young or old, and they say, I got this little click, 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 I don't have any pain. Well, you know what stage they're in. If they say, now I go to open and I hear this loud pop and it hurts, you then know what stage they're in. And when they come in and give you the other noises, and the other noises are really variable. When the bone-on-bone noises can be just about anything. Great grind, Rice Krispie sounds, a fluid sound, like I have had patients say, when I open and close, it feels like I have water in my ear. Well, the water's not in the ear, and they can actually hear the fluid within the joint sloshing around in there, or what's left of the synovial fluid, because it isn't really synovial fluid, it's inflammatory exudate. But they can hear the fluid within the temporal ear, so they'll talk about Rice Krispies and great grind crunch. Those are the sounds from bone on bone, which gives you another indicator of what stage of the degeneration they're in without ever even looking at the Panorex. I'll just make a comment, came to my mind. You don't need to get really deep into the diagnosis of temporomandibular joint using 3D CT. I mean, 3D CT, I believe in it greatly. And if you are doing a lot of dental implants or maxillofacial reconstruction, you definitely need and want to use a 3D CT. Do you need to spend the patient's dollars on 3D CT for your diagnosis of TMD? No, you do not. It's too much information. It really isn't necessary at all. It's nice to look at, and maybe you want to impress your patients, but that's not a reason to get, that is not a reason to get a radiograph. Regular old Panorex will give you all the information you need to know whether there is no degeneration within the joint or significant degeneration. You don't need to see the meniscus to make a good diagnosis of temporomandibular joint disorder. It makes no difference where that meniscus is as to how you're going to treat it non-surgically. It doesn't. So that highly specified view of the temporomandibular joint structures is really not necessary. What you really want, as I mentioned many times before, is a really good history. And a really good history will include a brief, very brief comment from the patient as from their noises. And you don't even have to note it in your chart if you don't want to, but the patients will give you a lot of information as they, at the beginning, tell you about whatever their signs and symptoms are, which brings up an excellent point. I want to drive this home. On these episodes, on this podcast, I have mentioned many, probably 100 times, what the usual and customary accepted symptoms of TMD are. Run through them again, hopefully not too fast for you. Headache, earache, jaw pain, neck pain, ringing in the ears, tinnitus, subjective hearing loss, which is fullness in the ears, most frequently described by the patient, vertigo, dizziness, upper shoulder and upper back pain, upper shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of locking, of which we briefly discussed. Those are your symptoms. Noise is not a symptom. Noise is a sign. And what are the difference between symptoms and signs? And in the description and examination and treatment of TMD, it's nice to know the difference between a symptom and a sign. Well, a sign is something that can be either heard or measured, collated objectively. So, you can hear the noise, even if it's not obvious to you, and you don't need to. I don't believe in listening with a stethoscope. If you want it just for interest, that's fine. Whether it's a mild, very non-impinging noise and you can hear it with a stethoscope, that's nice. But the point is, noise from the joint is considered a sign, not a symptom. And the treatment protocol and device we use treats the symptoms, and symptoms are not objective, but subjective. They're the subjective points or descriptions that the patient has. They're subjective symptoms that they will describe for you, usually in their own words, as to what's going on. And that is why, the symptom description that I just gave you, headache, earache, etc., they're all subjective. It just works out that the device and protocol will treat the subjective symptoms. We treat symptoms here, and I remind patients of that often, and this is the reason. So early on, years and years ago, it began to be obvious to me, as I told patient what to expect, and here's what the diagnosis is, and here's what I think. And your painful symptoms will usually start diminishing within the first couple of weeks, and the other symptoms of tinnitus, subjective hearing loss, or fullness in the ear, and vertigo, if they have one or more of those three symptoms, will take longer. And the patients would start coming back, and they would tell me, "Thank you very much. My symptoms that you talked about are gone, but I'm still having noise from my joint." And I had to kind of spend a little time kind of dissecting all this out and do a little deeper dive into it. And that is the point that noise is objective. Noise is a sign, and sign is objective. And it just works out that the urbanic device and protocol doesn't fix noises. And I then began proactively telling patients as I treated them, especially if they complained about the noise at the beginning. And frequently that is one of the number one things that they will say. I have this noise, and they'll describe it as a click, a pop, a grate, a grind, Rice Krispies, whatever. And just to make my presentation and understanding of this problem, as clear as possible, then I began telling patients when we're finishing up, this is when you can expect, this is what you would expect with the diminishment of the symptoms, headache, ear, etc. Bringing fullness, dizziness take longer to diminish, but don't expect the noise. It is a sign, not a symptom. And so we fix symptoms, and we don't fix the sign of noise within the temporomandibular joint. Now, the other thing about this that probably obvious to you if you see a number of these patients, and not known to you if you don't, is these noises change characteristics and change among themselves frequently. So you can start out with a click, then go to a grate, then go to Rice Krispies, and you didn't mention squeak. I've had many people talk about a squeak in the joint. The description from the patient is a subjective description, and what you're listening to is either a noise coming from the mal-movement of the meniscus, because it's not supposed to make any noise within a healthy joint at all, or you're hearing about the bone-on-bone action, which causes all of the other noises, objective noises that come from the temporomandibular joint. I intentionally didn't sit down and try to classify these noises. You can't, and that's the reason. You cannot classify these noises as to exactly what a noise means. You have an idea what they mean, and I went over that. Early noises, click, 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 click. Later noises of the meniscus in malposition being the pop, and then the eventual lock. In a closed, what we call closed lock, their inability to open beyond a certain range. Closed lock is usually at about 25 millimeters open, a full closed lock. And then the bone-on-bone noises. So don't get wrapped up with any kind of classification of noises, because it's meaningful. It's meaningless, other than to give you an idea of how far along the progressive timeline of the development of degeneration within the temporomandibular joint, creating inflammation within the joint, which the inflammation within the joint creates all of those symptoms. And that's the nuts and bolts of, that is the nuts and bolts of TMD, when you understand that. And then how inflammation actually creates each and every one of those symptoms is a longer explanation, which we've gone into in several of the episodes. It's available to listen to and watch. It's also on our course, which teaches doctors, dentists, oral and maxillofacial surgeons, and orthodontists that are qualified to become network providers for our company, the Urbanic Device and Protocol, which now has our completed study, which verifies all the claims that we make. And I would consider anyone who would want to use it in their practice to contact us and discuss the use of the patented device and protocol in their practice. Our study has proven that what our claims are, that the vast majority of patients who have TMD and one or more of all those symptoms will be relieved permanently using the device on a recommended basis throughout their life. And that's all described on the course. So that is kind of what I'd like to share with you today. I hope it helps you with your patients and in the everyday discussions and diagnosis with patients that you're sitting in the chair. This is, as we've talked about many times before, TMD and the related symptoms is a huge number of patients who have this problem, a huge problem. 45% of females have temporomandibular joint symptoms, nowhere near the number of males. Problem is 95% females, 5% males. And they will come into your office with any number of those symptoms, but one of the most common comments they will make going to the dentist and sitting in the dental chair and say, by the way, doc, my jaw started to click, or my jaw's popping and starting to hurt when it pops. And those are big red flags. Don't ignore it. Don't ignore it. It's just, it progresses. It's certainly better to treat it early. For sure. So you won't get into the degenerative changes that go on. Obviously, if you treat it early, you unload the joint, you decrease the inflammation, you will not get into the degenerative changes. You will not get into the degenerative noises. You will not get into the bone-on-bone noises. So thanks for watching. Thanks for your attention. Comments or questions can be placed at the end of the episode. And for today, I am Tony Urbanic, and this is TMD Demystified, and I very much look forward to talking with you again.